Let me introduce them all. They'll all join me on stage, and then each of them will speak for about 5 minutes. Then we'll have a discussion and very much a chance for you to ask your questions. So let me welcome them all. Sarah Hughes is Chief Executive, Centre for Mental Health. Patricia Miller is the Chief Executive of Dorset ICS. Jabir Butt is Chief Executive of the Race Equality Foundation. And Dr. Bola Owolabi is Director for National Healthcare Inequalities Improvement Programme, NHS England. And a reminder to all of you that this session is being live streamed. I'll just move my glass over. And those are all clean glasses otherwise. Just move that out of the way. Right. Let me just see where we start then. So I think you've all got some reflections really on how providers, system partners, anchor institutions can work together to reduce health inequalities. I'm going to start with Sarah.
Thank you. So firstly, we'll take my glasses on and off, not because of any other reason than I sat on them, and so they look really wonky, and I can't really see properly out of them, so apologies if you think I'm fidgeting. Anyway, that's the truth of the situation. So look, thank you so much, and it's great to be here, and every time I'm in the company of NHS and care colleagues, it's always really important for me to say a heartfelt thank you for all the work that you've done. Solidarity in these times, I know it's incredibly difficult. So thank you for all that you do, and also thank you to Saffron for, I think, what was a great setting of the scene, painful and moving though it was. So look, we're here to talk a bit about, what the system can do and so on and so forth. And I think, look, we're probably preaching to the converted in many ways. But when we think of population health, we can get caught up with thinking it's the property of our public health colleagues. In reality, of course, it's everybody's business, everybody in this room, everybody on this stage. And when I thought about talking to you all, I thought, well, okay, what definition of population health are we talking about? And of course, our dear friends over at the King's Fund always produce the goods and have come up with a definition that I think really applies to all of us. And they talk about population health being a focus on the social determinants of health, health behaviours, so, are people smoking? Are they, eating donuts for breakfast? Places and communities, what's the nature of deprivation, what's the nature of opportunity in the areas that we're providing services in, and really truthfully thinking about integrated health and care systems. So look, I come from a mental health perspective and have worked in mental health for a very, very long time. And I think, what we know, the social determinants of health are probably the most critical in thinking about how we can turn the tide on the mental health crisis. Now look, we're in a time like no other, but we do know that children who live in poverty are more likely to experience a mental health problem. We know from past experience that the recession leads to an increase in suicide. We also know that racism is toxic to people's health. And we also know that the pandemic revealed things about our health and care in a way that we can never unsee. The brutality of this exclusion wasn't new news, of course, but the explicit and persistent harm to people from racialised communities particularly was horrifying, terrifying. So I have stepped across the corridor and have joined the Integrated Care Board at Cambridge and Peterborough. Is there anybody from Cambridge and Peterborough here? Hello, dear friend. So look, so I am now on the ICB, and apart from coming out of meetings and then having to spend 5 minutes in the brace position, apart from that, I'm loving every minute of it. And I'm loving every minute of it because it's truly teaching me something about how we do business, how the system operates, how people within our health and care system are trying every single day to make things better. So I know the struggle is real. The challenges faced by every area is complicated by a lack of people on the ground, a workforce that is burned out with patient acuity across each health domain increasing. Now is not the time, though, repeating our mistakes. This is a once-in-a-generation opportunity to truly transform our community's experience of health and care. This is not to say that money isn't required. Look, I'm not somebody who will sit here and say transformation alone will get us out of this crisis. I think that the transformation agenda is part of it. I'm a bit like, Tom Cruise. It's like, show me the money. We need the money too. But it's not about spending the money on the same things. And I would challenge us to think about bravely putting communities first. And what does that truly mean? So if we're going to be brave and radical, I think some of us are doing some of these things some of the time. We're not all doing these things all of the time. And I think that's the challenge. So what do I mean? And these are in no particular order, and I've got to move on at some point, so let me just speed through them. So leadership at every level. When I talk about leadership at every level, it's really about lived experience. It's about hearing people at every level of your organisation, giving our frontline staff the opportunity to really understand the problems, but also work with us on developing the solutions. We really need to develop and fund innovation. And it's really hard, isn't it? We've got to fund the here and now, but we've also got to fund what's going to help us in the long term. We need to challenge the hierarchy of evidence. So look, I currently work for one of the leading mental health and social justice think tanks in the world. And we use research all the time, but we challenge the entire system to think about, we use evidence in a way, well, if it's not an RCT, we can't use that, or if it's not approved by NICE, we can't use that. But actually in communities, we're doing things every single day that are making big differences to people's lives. So I wonder if we shifted around our focus in terms of the hierarchy of evidence, what would that look like?
And Sarah, just to be aware time-wise.
Yes, I thought I would go over, which is why I have a list. Negotiate new relationships beyond health. Give up some of your power and meaningfully give it up. Give it to your partners. Give it to providers. Give it to communities. Compassionate cultures. The NHS, bless you, are not the best at compassionate cultures, and we can see that through staff workforce feedback for all sorts of good reasons, but it's still not entirely compassionate. That we need to be a learning environment, not a blaming environment. And we need to have data that the world envies, not data in pockets or just half the data. And this is what health creation is, not what we do at the moment, which is health reactivity. So on that note, I'll pass on.
Thank you so much. Thank you, Sarah. Patricia.
So I'd probably echo a lot of what Sarah's said. I think this is a one-in-a-generation opportunity for us to really do things differently, because I think the NHS sees the world through an incredibly narrow lens and can play a much wider role in terms of health inequalities and social and economic development of our communities. But it does require courage, and it requires completely different thinking than where we've been in the past if we're really going to honour the original purpose for which the NHS was established, which was about reducing inequality and supporting people to stay well, as opposed to looking after them when they become unwell. But systems are not an entity in themselves. They are a collection of partners from all different walks of life who come together with a common purpose and a sense of mutual accountability. ICSs have 4 strategic objectives, but for me the real prize is in the ones that focus on reducing inequality and supporting social and economic regeneration. They're intrinsically linked to each other. And why do I say that? Because only 20% of our health and wellbeing is dictated by any intervention that health makes. The rest of it is about housing, the quality of housing you have, where it's based, employment, education, social mobility. It's all those things that really matter. And we have a serious part to play in that space as providers, and we don't always take that opportunity to do that. And that's where breaking out of this narrow lens is really important. Household wealth plays a significant impact in social mobility. We know that if you live in the top 20% of deprivation, even before inflation, you were having to spend 3/4 of your weekly income to eat healthily. That means you're regularly choosing between food, heat and rent. And that's not a place we want to be in. And again, we have a part to play in some of that. So I think providers have a number of roles in this space. Yes, we need to improve access to service, but we need to rewrite our constitution. The fact that we've focused on equality of access for so many years has been a major contributing factor to inequality within our community. So we need to move to equity of access and differential investment, and that takes courage. Because we have to bring our communities on board with that and explain why we're investing less in one area because another area needs more investment if we're going to raise their health and well-being up to at least the average. We need to improve outcomes and we need to reduce variation where we can. There is absolutely no reason why Hospital A in Dorset has completely different outcomes than Hospital B for the same services. So we need to work really hard on that, and that's about common approaches. We need to think through how we deliver on the core 20+5 and how we recover lots of our services post-pandemic, but not by doing what we've always done, but by doing it through a health and equalities lens. That together is our contribution to the 20% that only health can do. But the wider role for me is how partners really make the best out of their role as anchor institutions to really deliver on that 80%. That's not just about being a good employer. It's not just about pursuing the greener agenda. It's also about things like how we procure services. Do we support communities to form community interest companies that we can procure from that keep local people in jobs? Are we adventurous about how we use our estate to maybe provide affordable housing as opposed to keep expanding capital facilities when actually what we need to be doing is providing more care in the community? But none of this can be done alone. We need partners in order to be able to deliver on this agenda. And the most important partner is our communities. That's where real subsidiarity comes in. How much are we willing to devolve and the accountability, the responsibility to our communities for supporting us to make the right decisions about where public sector money needs to be spent? How are we going to support them with the trade-off conversations with us so that we're absolutely delivering what they need? How are we going to understand their lived experience so we can really deliver person-centred care and co-design the solutions to some of our more serious health and care problems with them? And that requires courage. But for me, I would quite like to see in the next 5 years that when we look at our average ICB, actually, yeah, there are officers on there, but they're outweighed by community representation. Because when we get to that point, we've really created communities where citizenship matters and they're in control of how services are delivered.
Fantastic. Thank you so much, Patricia. Jabir.
The temptation often when following other speakers is to say ditto and sit back and let the next speaker speak. But hopefully I've got a couple of things to say that might be of interest. Saffron usefully reminds us of the data around racial inequality in the NHS, but can I just reframe it for a second? The NHS continues to be the biggest employer of black, Asian and minority ethnic people in this country and probably in Western Europe. Something like 250,000 black, Asian and minority ethnic people work for the NHS. And I would argue for the majority of them, it's an occupation of choice, not because they couldn't do anything else, but because they actually want to work for the NHS. Unfortunately, the evidence tells us, however, that experience, that willingness to be part of this great endeavour doesn't always pay off, doesn't always achieve the sorts of change that we need to change. And if we start with the start of life, for example, the evidence of late is worrying. We've had a dramatic improvement in infant mortality over the last 20 years, and it's an achievement to be proud of. However, what hasn't happened is that we haven't narrowed the gap between black and Asian mothers, the infant mortality for black and Asian communities and their white counterparts. That gap continues to be as large as it was 20 years ago, and that is a real worry. Unfortunately, as the Embrace report this week demonstrated again, it's accompanied by higher rates of maternal mortality as well for black and Asian mothers, something like 3.5 times for black women, something like 1.8 times for Asian women. Again, something we've known about for some time. The first report indicating this appeared in 2007, and yet we're still showing the same experience. If we move on and look at the data from the Learning from Deaths reviews that are carried out on the deaths of people with learning disabilities, again, it shows that people with learning disabilities die younger than their able-bodied counterparts. It unfortunately also demonstrates that black, Asian, and minority ethnic people with a learning disability die even younger, something like 10 to 15 years younger than their white counterparts. Again, when you explore that data, it suggests that they're more likely to die of preventable diseases than their white counterparts, demonstrating a real change. Work that's been done by Naheed Mukaddam recently, looking at dementia, suggests that black and Asian people are more likely to be diagnosed later than their white counterparts, and are likely to survive for a shorter period after diagnosis as well. These are all problems that we need to be addressing, and yes, they are impacted by the wider determinants, but they're also impacted by the care we provide, and we need to make sure that that care is as important. And there are examples of real change. City and Hackney, in the rollout of personal health budgets, have worked with the Advocacy Project and have worked with a number of local organisations such as Coffee Afrique to change the way PHBs are delivered, and to ensure in delivering that they reach out to City and Hackney's black, Asian and minority ethnic communities. And the latest data shows that they actually work with more black, Asian and minority ethnic people than they've ever done before. As importantly, they've demonstrated real improvements in well-being for those people with severe mental ill health in those communities. We've replicated that work in Blackburn with Durban, again, working with local voluntary and community organisations such as Mind, such as Age UK, but also the Healthy Living Centre in Blackburn and Durban to bring about those change. But the challenge we face is that these examples of better practice tend to end up being just examples of better practice rather than systemic change. And I think that's what we really need to work for, is how do we ensure that racial equality is being done by everyone and is being seen as everyone's job rather than just something that's nice to do when we can.
Thank you so much, Jabir. I think that's one thing we'll try and talk about in discussion as well. And Bola.
Thank you, and thanks everyone. It's really good to be here. Thank you to my co-panelists for your really deeply insightful comments. I also want to start by saying a huge thank you to you all for all that you're doing in the face of maybe the strongest headwinds that we've all experienced for quite a long time. Resilience. I want to start where Saffron left off. She said, there is hope. And when I go around the country, whether to the coastal communities of Cromer in Norfolk, or Clacton-on-Sea, or indeed other areas experiencing the greatest health inequalities, I find that we are drawing our resilience to tackle health inequalities from a number of things. I see that we are drawing resilience from moving from the burning platform that the COVID pandemic created to a burning ambition to narrow the health inequalities gap. As tired as people are, the one thing that I never see people tired of doing is to address the injustice of health inequalities and the unfairness of it. That's one space where there is energy always. I also see us drawing resilience from focusing on our circles of influence and recognizing that there is something we can do. So whether that is University Hospitals of Leicestershire, who looked at their did not attend rates and found that it was our most underserved communities, and they mobilized their volunteers to find out why, and they began to put things in place to address that. The DNA fell by 50%. or whether we look at Airedale Hospital, who worked with the Hope for Tomorrow charity, and they put buses, mobile units, so that we can diagnose cancer earlier in our underserved communities. Or whether it's the dental aid van that I found on the quayside in Cromer, providing much needed dental interventions for people whose lives are ruled by the waves and can't wait for a routine dental appointment. I find that in that there is hope. I find that we're finding resilience in working with our partners, with our local authorities, with our voluntary sector colleagues. Like Newcastle Foundation Trust working with HealthWorks charity and with the local authority supporting people on the elective waiting list, to the point that some of them are able to come off the waiting list, or indeed they're as fit as they can be for surgery, and we don't have the loss of productivity from the cancellation of theatre times. Or indeed the work that Islington Council is doing, training their barbers to help Black men talk about their mental health challenges and not relying purely on what the NHS can do as a lone actor. The NHS as an anchor institution, the work that Birmingham have done, providing accommodation for young people experiencing homelessness, giving them apprenticeships and work placements, and at the same time helping them not to need to access state benefits in doing so. I see resilience in us actually leveraging that role as an anchor institution really powerfully, whether it's what Imperial Hospitals are doing in their Compassionate Communities projects, really reaching out to those communities at the margins of their community. What Calderdale and Huddersfield did when they looked at their electives waiting list and they eliminated the waiting for people with learning disability. I can go on. What I'm trying to say is that in the middle of all of the headwinds, amidst all of the challenges, you and others right across the country, we are drawing resilience from all of those things. And as we go forward, I think we can go still further. We can go still further by digging deep from what we did so powerfully during the COVID pandemic response. We developed a different relationship with data. And rather than just using data to give us assurance, we used it as a source of insight to drive improvement. The second thing we did was we took a strength-based approach. We looked at our communities, our underserved communities, and we refused to see them as bags of needs. We saw them as equal partners in finding answers. And that strength-based approach led us to co-production. We met with the pastors, with the imams, with the faith leaders. They told us where to put the vaccines in order to have the greatest impact. And so I have hope on the basis of all of those examples and many more that I can't list in this short period of time. I have hope based on all that we did together during the pandemic that we can narrow the health inequalities gap. So let's go forward and do exactly that.
Thank you so much, Bola. And what a positive note to end those presentations on. Thank you all. One thing that struck me was so many of you gave very specific examples of where there's really interesting, positive work about tackling inequalities. And yet, as I think you said, Jabir, there's this sense that it's not necessarily being picked out and lessons learned across the broader sense of the NHS and its trusts. What are all your thoughts about taking these examples of good practice and trying to get those lessons learned and then turned into a kind of wider spread use of good practice? I don't know if you want to take that one first.
I think the issue's been that we've developed frameworks in the past, we've developed attempts to make things structural rather than just a particular practices, and it's not always worked. But I think Bola's work around the Core 20+5 has been one of the ways that we've actually started to translate that individual experience into a system-based experience, and I think that comes through. A key issue, though, has always been about leadership around issues to do with racial equality, but I suspect around many other as well. And I think when we've had leaders who've actually said, this is not only something that I've been asked to do, but this is something I want to do, it has made a real difference. And I think we've started to see that happening now.
Yeah, Sarah, Patricia, your thoughts on this?
I mean, I think this is where the ICS gives us the greatest opportunity, really, because one, I think it allows us to, around the 42 areas, really share that best practice here and other opportunities, but also I think really make sure that they are pertinent to your local population. I think that where we've tried to helicopter in great ideas from one place to another before, that doesn't really work. And so it's really about getting that idea, really thinking about, well, how does that work locally? And so I think this is where it gives, this is the greatest moment for that type of transformation that I think we've ever had. And so I think it's for us to seek out the innovation, to really seek out the opportunities for learning, and then to try them out. And I think part of that means that we have to, it's kind of, we use a term in our ICB, but I can't remember what it was, but thinking about, doing risk well, effectively. Yeah. And some of that is about trying things that may not work.
Okay, Patricia.
I think there are lots of opportunities now to be able to work differently and to share innovation. So I think the ICS is a really important vehicle for that. That enables you to try, test and move those really good practice around your system. And I agree with Sarah that it's not about lifting one method of doing something and just thinking we can translate it into every ICS, because that takes away an element of local community accountability and decision making around how services are delivered and accessed. But as the 42 ICSs, we come together regularly with NHS England's leadership team. So I think there is something about us using some of those events and being more in control of the agenda that shares good practice. And Amanda pulls together all of the provider and ICS chief executives on a regular basis for the day. So again, I think we need to think a bit more about how we use those vehicles of communication to really share things that we're doing that could benefit other communities.
Thank you. Bola.
Yeah, absolutely. Echoing what colleagues have just been saying, I just want to pick up the point about leadership. I think leadership that chooses very intentionally to do three things. To move from the rhetoric into reality, and to stop an endless focus on policy and moving it into the practice space. I think that sort of leadership that is enabling is really powerful and important. And when you see it happen, change happens. I think also clarity of direction. Yeah. And that's what we've tried to do, because change starts with the first next practical thing that I need to do, which is why we set out those 5 strategic priorities for tackling health inequalities, that we're going to restore our NHS services inclusively, that we're going to mitigate against digital exclusion, that we're going to ramp up our ethnicity coding, that we will move forward with our preventative interventions, and that we will strengthen leadership and accountability. Having those clear priorities, and then how am I going to do this? And as Jabir said, that's why we set out the Core 20+5 approach. It's not the totality of health inequalities, but it's a great place to start. It gives us focus, and that focus will give us a chance to gain some traction on this complex issue, and within a reasonable time frame demonstrate that we're making some impact. So I think it's about leadership, it's about clarity of priorities, and it's about being clear, what do I do next? And people can start with that.
Thank you.
And I would just add that I think we need to be very intentional over the next 12 months about our move away from recording activity and moving towards measuring outcomes. Yes. And yes, there is a place for some of the activity recording, because we need to demonstrate productivity in terms of value for money for public spend. But I think we need to be very intentional about moving towards outcome-based contracts, commissioning, delivery, because that's the way that we demonstrate that our communities are getting what they need, that we're making that impact on health inequalities, and that we're delivering value for money.
Yeah. So just a comment that's come in, we know that the things we pay attention to are more likely to happen.
Yeah.
Why don't the national leaders ask us about and hold us to account for progress on these, rather than calling CEOs about daily operational targets, which is very much what we've been saying.
Exactly.
Another issue which is for thinking of is, you know, we know that in the current environment there are so many issues, you know, cost of living crisis, lack of affordable housing, low income poverty. The NHS can't make all of these go away on its own. And I want to add it to a question that's come in. You know, everyone supports the equality agenda. Given the lack of progress on the government levelling up agenda, the limited funding for the NHS, the massive focus on waiting lists, how can systems introduce differential investment and retain public support and meet central targets? I think there's, you know, that understandable worry that the NHS could be being asked to do too much, even though we know how important tackling inequalities are. Who wants to take that first? Bola?
Yeah, happy to. A couple of reflections. I think it's what I was saying earlier on about finding resilience in partnership. I don't think this is a call for the NHS to fix housing, employment, household income as a lone actor, which is the opportunity of the ICS, as colleagues have said. I think it's that proactively and intentionally working with others in order to deal with those challenges. That's how we're going to make real progress, would be the first thing that I would say. And we've named a number of examples, you know, around the country where people are doing exactly that. I think the second thing is to reframe how we talk about health inequalities. It's not the thing we deal with when we've dealt with today's pressures. In reality, as I've said before, health inequalities are the very fuel that are driving the fires of today's pressure. You know, the people who are turning up in A&E repeatedly with no medical reason to do so are doing so because of the health inequalities and complexities of their lives, as the British Red Cross told us so powerfully in their report last year about how actually less than 1% of the population is driving a third of the pressure on our urgent and emergency care services. So I think it's that reframe of actually tackling health inequalities is how I address the immediate pressure on my services today. Even in terms of workforce productivity, you know, people living in health inequality, they start with long-term conditions earlier, they accumulate them faster, they live with them for longer, which means they're out of the economic circulation for much longer. And despite having nearly 20 years less of healthy life expectancy, they command a greater proportion of our health expenditure in emergency admissions, prolonged hospital stay, delayed discharges, UEC usage. So it's a false dichotomy to think that health inequalities is the thing to come to when we fix today's issues. It's the thing driving today's issues, and that reframe will actually help us in how we reorientate our resources, our efforts and our energies, and the way we talk about this as well.
That's what Saffron was saying earlier about the need for long-termism and not short-termism. Other thoughts on
so I think that
this issue?
I absolutely agree with what Bola said. It needs to be an integral part of the way we work. It's like the inclusion agenda. It's not something separate that we do when we've got time. It needs to be an integral part of organisational strategies and people plans. And we know that we've got to stop thinking about health inequalities as being a burden, and actually recognise that for every pound that we spend on health and wellbeing, the economy gains £4. Pre-COVID, inequality in our communities cost the economy £37 billion a year. That's almost the amount of money that we now need to save that we're going to be given extra taxation on Thursday. So we've got to start to see that investment in health and wellbeing is actually it's a positive outcome. It's not a burden to society. It will reduce health spend, it will reduce the dependence on other public sector and non-statutory services, and it boosts the economy. And when we start to see it like that, we have a massive role to play in levelling up. It's not just about government agenda, it's about the way we operate in partnership with others to be able to deliver better outcomes for our community. And I think in terms of how we get our communities on, keep them on board with what we need to do, we only need to look at the success of the Wigan deal, pre-austerity, and the impact that had on the health of the population in Wigan and their behaviour in terms of citizenship and sensible use of resources, to know that if we have an adult-to-adult relationship with our communities, if we engage them in an equal conversation around what the issues are and what the solutions are, and then we co-deliver with them, that conversation around priority, it becomes much easier because they feel part of the decision-making process, because we're respecting them to be part of it.
Yeah, Jabir?
A key thing that nobody's quite talking about is that it's all got to do with politics. We can't get away from the fact that actually, until we're in a situation where politicians actually believe in prevention and actually want to invest in prevention, we're not going to make the kinds of changes in the social determinants of ill health that we need to. And unfortunately, I've heard almost every health secretary say that they believe in prevention, but then decide not to invest in it, and often actually cut the public health grant just as one manifestation of that. And I really do think that until we're able to show leadership around that, we are going to continue to face this thing of ever-increasing pressure on the NHS and ever greater challenges in addressing that pressure.
Thank you.
While I resist the temptation to chain myself to number 10 Downing Street on that basis, the deal is that I think, I agree with you, I think the public are really ready for an honest conversation about what the situation is. And so when I think about the comparison with mental health, we've spent a long time talking to the nation about mental health, and I think we've got a literate nation now. But the conversation is ready for the next step, which is how do we actually create good mental health? And we do that by having great communities. We have that by having good housing, by having a welfare system that doesn't penalise you. So I think that there is a nuance here that we need to develop. The anchor organisations, this is an opportunity to do that, to have conversations with your communities in a way that you might not have done before, to bravely say, okay, these are the challenges that we're facing. How do we together create the solutions? And I don't think that at the moment we're doing that in quite the way that we should. So we've got a lot of news reporting around A&E waiting times. That's really important, but there is a whole health and care agenda that's being lost in that narrative.
Absolutely. Right, here's a question that's getting a lot of interest. Health inequalities have been persistent and previously only driven by individuals, be it gypsy, traveller, homelessness or race health equity. The problem with that approach is it does not last longer than the individual. Are we seeing systemic change? Because in a sense, some of the examples you've given, I imagine that they've come from initiatives brought by individuals in certain communities. And there is this concern that systemic change is what we're all talking about. How far are we to actually seeing that breakthrough?
I think we're at the foothills.
Yeah,
I think we know. We're literate around what we think system change is. We've got great pockets of examples around the place, around the nation. But it's those kind of tactics around, leadership at every level, sharing power, sharing money, really paying attention to lived experience in communities that really is the sustaining of systems change. And quite frankly, we're just not very good at that. So, as soon as I was going to swear, but I won't. But as soon as things get hard, we retreat into that command and control approach. And, while sometimes, like during the pandemic, that might be really important, that is not a sustainable way to create systems change. But it's really hard for the NHS, particularly, to step outside of that. And I think that's the challenge, really.
Ola.
I think it's a great question, actually, that how do we move from the kind of individually driven approach that only lasts the cause of the individual? It's about social movements. And I think, everything that we're talking about is a social movement of the NHS with its voluntary sector partners, the NHS with its local authority partners, not just anchor institutions, but anchor systems. I think therein lies the longevity and also the sustainability of the agenda. I think also that more holistic view is really important. And for those who may not be close to it, that's why when we talked about the Core 20 Plus, just to really quickly use that as a way of explaining what I mean by the holistic view. So the Core 20, they're the 20% most deprived communities, and that's regardless of race or ethnicity or anything else. And that's determined nationally. But the plus group, they're determined at the ICS level using your population health data. Who are your plus groups? For some ICSs, those would be people from ethnic minority communities. For some ICSs, those will be coastal communities. For other ICSs, it would be Gypsy, Roma, traveler communities. For others, it would be communities experiencing homelessness or rough sleeping. Hence the flexibility of the plus. So I think the longevity and the sustainability of the health inequalities improvement agenda is in the social movement approach, the partnership that we've talked about, and not siloing it into individual communities, because this is a far more holistic issue than just one community, and that's what the data shows, and that's what the pandemic showed as well.
If I can just explore one example, we seem to have forgotten Sure Start, but Sure Start was an attempt to deliver systemic change, not just in the experience of children from 0 to 1,000 days. There was a real attempt to work with the communities and to actually do things that made a real difference to those children and young people's well-being. But what we did was we stopped investing in it before we were able to demonstrate its impact. And unfortunately, that's the real challenge we face, is how do we sustain that attempt to bring about systemic change? Because Sure Start now is, the latest evaluations are showing, did have an improvement in educational attainment, did have an improvement in well-being of those children as well. But we've moved on. We've actually taken away all the money from that as well. And I think that's why politics, again, really matters.
It's funny, I was thinking a lot about Sure Start. I also met someone the other day who said that for all the positives, there was actually a gap between it being a nationally kind of brought-in system, and sometimes it was missing local need because it wasn't driven from community upwards. So I think within that example too, it reveals what you've all been saying, which is the importance of listening to local experience first.
I was giving evidence to the Health and Care Select Committee last week, and one of the questions I was asked was, the NHS loves a reorganisation. How can we make sure that the systems deliver? And I think there's a few things in my mind. There's one, it's in our gift within NHS England to decide if we're going to have the courage to test system working for long enough to make sure we're absolutely getting what we desire out of it. And the reality is we're late to this party. Other parts of the world have been delivering integrated care on a system level for a long time and are delivering good outcomes. So I think that's the first thing. NHS England know they need to change in terms of the way they monitor healthcare, the way they work with systems and partners. And Amanda will talk when she's here about the fact they're up for that organisational development change that means that they are driving a systemic movement that delivers something different. But the challenge I would give us is, actually, it's up to all of us in this room. We're the NHS leadership. If we want systemic change, we need to drive it. And that means us accepting that we have to see ourselves, and I was a provider chief exec previously, it's about recognising that as organisations, one, we can't deliver any of this by ourselves. Two, we don't exist for our own purpose. We exist to work in a wider system to deliver good health and care. And it's about leadership. It's about the fact that when we are in that sticky moment with wicked issues, that we stop looking internally within our organisations and do we develop the outward mindset to look outside to partners to solve them, because that's how we'll embed a different way of working.
Well, it's funny, you lead me on to a couple of points that have been raised by delegates. So success relies on moving from niche to mainstream. We will improve life expectancy for every person with a learning disability if every service engages. We need less specialised services and more inclusive services. services. And I want to add to that a specific question which has come in. 80% of the determinants of health are from non-medical interventions. The third sector is skilled, innovative and energetic in these areas, but still largely disparaged or dismissed by the NHS in the view of this person asking the question. How can we change these attitudes and exploit these opportunities?
Gosh, that's
Sarah,
a great question. Do you know what? I've spent 30 years. This is the first time I've got an NHS email address, and I feel like, you know, it's like
Turn to the dark side,
yeah. I feel yeah, it's a bit dodgy, I have to say. But look, you know, I've been in situations where working in a mind organisation, trying to refer somebody into a statutory provider, and the statutory provider saying, you know, what qualifications do you have to refer into? At that point, you know, I probably had more qualifications than the person asking me. So I think that there is a huge still stigma and kind of just a lack of understanding about what the third sector provides. And so charity isn't tea and sympathy, although it might be what is delivered. So tea and sympathy, we might get people in a room and we're having tea and empathy, and there might even be biscuits, because, you know, in the third sector we have biscuits, we're not like the NHS. You know, there might be that, and that is an opportunity for, you know, people to talk, to explore, to think, and that is a really sophisticated intervention. Don't underestimate that. And I think we time and time again have conversations, and my ICB is trying its best, but I still have to push and say, don't have the language around, you know, let's just get the third sector in around the periphery. If they're not at the centre of the conversation, then you're not having an inclusive system. So it's just a kind of, you know, it's just a bit rubbish if we haven't evolved our understanding of what the third sector are providing. And I think it's time for the NHS, and this is where I'm talking about stepping out of your power, stepping out of your power for 1 minute to really understand what our charities are doing every single day. And if you went to see them, if you went to spend days and time and watched what they were doing, it would revolutionise your perspective.
A key issue here is, who do you actually think is doing health and care work? Sarah's organisation, my organisation, many other organisations have repeatedly demonstrated for Black, Asian and minority ethnic people with mental health problems, the voluntary sector is often seen as the trusted place to go for support, and the place where people do identify as being receiving positive support. Yet they're not part of any framework that sees them as being part of the NHS workforce. They don't get training, they don't get the rates of pay, they often aren't even counted by the NHS as being part of the workforce that needs to be addressed. HEE have only recently started thinking about what is the training needs there and so on. And I think as long as we continue to exclude what's often seen as a trusted place to receive services, we're going to have this challenge of not actually engaging with the voluntary and community sector. I'm not arguing it's all perfect. I'm not arguing that they all do a brilliant job. However, it's often seen as being a fundamentally important part of addressing inequality, and we're not really engaging and supporting it in the way that we should. And social prescribing has just been the latest incarnation that's demonstrated that we don't really appreciate what they do, or we don't value it by giving it the money that it deserves.
Thank you. Bola and then Patricia.
Yeah, thank you. I think three things. One is the issue of trust, just picking up your point. I think it's Professor Kevin Fenton who started saying this, and it's true, you know, that one of the things the pandemic did was show how trust itself is a social determinant of health. And who were the people who helped us? You know, the voluntary sector organizations, the trusted voices and faces in communities were the ones who came to our aid. And I think it's about, as we recover, reset, whatever word we want to use, how do we not recoil back to how it was, where we couldn't really see the contribution that the voluntary sector partners made, but actually remember the contribution that they did make in our hour of greatest need during the pandemic, and harness that and codify that as part of the way that we work going forwards. I think that's the first thing. The second thing is sometimes we see them, as you were saying, on the, you know, as Sarah was saying as well, on the peripheries rather than integral to the necessary work we need to do. And I remember meeting lovely Elliot at Mid and South Essex NHS Foundation Trust. Wonderful gentleman with learning disability and autism, who was running a fantastic operation in the pharmacy department, in the dispensary. It was just extraordinary to watch him at work. And that's because they partnered with their local sixth form college, and also another charity that was supporting people living with learning disability and autism. And they came together and created this apprenticeship, this 12-month apprenticeship. And lo and behold, Elliot is running the shop fantastically. Everybody else can run around and do all the other complex things that need us to run around, but his beautifully wired brain was holding the ring on that dispensary. And it's about how we begin to see the power of the voluntary sector to help us address our issues, is the other thing I would say.
Thank you. And finally to you, Patricia.
I think some of it is about trust. So in our ICB, the voluntary sector has sat on the ICB as an equal partner, and we've got a number of voluntary sector representatives sat on our integrated partnership because it's an important relationship. And I think it's a little bit like local government. Health in the past has always approached local government and the third sector when it can do something for health rather than seeing them as an equal partner to decision making. So I think those things are really important. We've taken a different approach to our strategy in that we've absolutely agreed one of the core principles is that it needs to be community driven. And so we have mirrored some of the Wigan Deal approach, where we've trained lots and lots of staff to interview members of our community from all walks of life in their own homes and in different environments to understand what they need from public service. And one of the key things that they've come back to us with in terms of the themes that have been built into the strategy is we need you to strengthen non-statutory services, because the reality is when we're recovering from mental ill health or physical ill health, that's the first place that we go to. So we've got to accept that. That's a reality. And we need to now form a different relationship with the third sector that sees them as an equal partner to deliver it.
Such an interesting place to lead the discussion. There are more brilliant questions. I'm sorry we don't have more time, but I think some of the questions that I've seen come in that are unasked will definitely be brought up in future sessions. Thank you to my terrific panel.